Very much, Joe. Thanks. Thank you. Hi, thanks very much, and thanks very much for Pro Patria. Thank you for Jason for reaching out to me. It's a real pleasure to be part of the community in Wagga, to really, mostly to be part of the Pro Patria organisation and having watched it grow from an idea and the defence shed to what it is now. And we're very proud at Monarch Mental Health to have our clinic in the Pro Patria Centre and to be able to have the opportunity to treat the people of Wagga and the veterans of Wagga, and offer them some new hope with treatments. So today, are we up? Did you get this? Oh, there we go. Great. Okay. So who is Monarch Mental Health Group? So I founded Monarch Mental Health Group with Professor Paul Fitzgerald back in 2015. So we've been going, quite a while now. And our mission is really to help more people recover from mental illness. And the why of this mission is the observation that I think everyone in the kind of, every psychiatrist and psychologist and mental health professional I meet understands, but also most of the people who have lived experience of mental health understand, is that a lot of the treatments that people conventionally use don't work. So if you have, you see your GP and you try a number of antidepressants, you see a psychologist, and they all do the right thing and they all do a good job. What we find is that 2 out of 3 people get a response. They get better often, they go about their normal life, and about fairly consistently 1 out of 3 people, just those things don't work for. And in the past, certainly in the first half of my career, I've been a psychiatrist for 20 years, in the past what you did was you just accumulated more and more people within your practice who weren't responded, and you just kept on trying the next new medication that came out. And by and large, it wasn't very effective. So from that observation really came my personal mission to say, well, what do we do with the other third? What do we do with those people? What's going to be available? And that led me down a kind of, for me, what is really a lifelong journey now of always looking at what the next step is. What are the next treatment? What's available? What's safe? What's available? What can we use? What offers people hope? And we're really lucky now in 2025 that we have at least 3. We have 3 treatments that can be very effectively used and very safely used as the next step treatment for depression, PTSD and anxiety. And we've got probably another half dozen other treatments that are waiting in the wings. So it's only going to get more exciting. And with each of these new treatments, what we're seeing is we're able to make a big impact in that 1/3 of people that didn't respond. So at Monarch, everything we do is outpatient. I think that's really important because I think when you put people in hospital, they lose function. We're at the moment the largest outpatient provider. We have 19 treatment centres. We're from Sunshine Coast in Queensland down to Mornington, Geelong in Victoria. We've got clinics in Canberra, we're obviously here in Wagga with Pro Patria. And that's good because when people are having treatments, mental health treatments are often longer term treatments and you don't always want to do it in the same place. People go on holidays, they don't want to just stay in Wagga, they want to go to Sydney or Queensland and have their treatment as well and not have their life interfered with. And at the moment I'm really proud that about 65% of the patients we treat are veterans and first responders. So we're not a pure veteran first responder organisation, but that is a big part of what we do. As I said, we've got a national footprint. I'll get straight onto this. So what are next step treatments? These are the things I'm going to talk about today. Transcranial magnetic stimulation, esketamine, which is nasal spray ketamine, and psychedelic-assisted therapy. Everyone's always very excited about the psychedelic-assisted therapy. That gets all the kind of news. But really the first 2, from a convenience and ease point of view, are probably going to be for most people, going to be their first next step. When I look at sort of what we've done with some of these next step treatments at Monarch, TMS, transcranial magnetic stimulation, it's been around for, well, probably for 40 years. It was invented in the early 1980s. It's been a fairly mainstream treatment, you know, in other parts of the world, at least since the early 2000s. When I started doing it in 2015, we were the first group that had been doing it. So we were running about 10 years behind in Australia at that stage. And I'm very proud to say that in that time, you know, partly from our leadership, partly from Professor Paul Fitzgerald's sort of academic sort of lobbying, it's really sort of taken off. So TMS is now broadly available in most communities. There's a Medicare item number for it. It's supported by DVA. There's really no issue with it, and it's kind of it's a safe, easy, convenient treatment. And we treat sort of, you know, we do about 4,000 sessions a month of TMS. The next step, which I think is for most people the logical second next step, is ketamine. Now, the problem with ketamine is that ketamine itself has never been approved for depression, anxiety or PTSD. It's approved in the use of pain. Fortunately, esketamine has been approved, so we can now safely use it. Now this is important because it actually goes towards sort of funding bodies. So if you want to do a treatment and you want it in a funded environment, then having an approval for the treatment is really important. And esketamine's been available since 2020, and from May this year, it became much more available because it was listed on the PBS. So really the only group that could access it, and this group probably is in that group, were veterans and workers' comp and first responders. They could access it. But from May this year, pretty well anyone in the community can access this treatment at a reasonably low cost. The next thing is the psychedelic-assisted therapy, and that was something where Australia went against the type. We were kind of a bit behind the world in both TMS and esketamine, but we were the first country in the world that made MDMA therapy and psilocybin therapy available for clinical use. You know, it had been available for compassionate use, end-of-life trials, clinical trials in other parts, but we made it available for clinical use. We changed the rules in mid-2023, and the first treatments were delivered in Melbourne by our team in January and February last year. And since then, our group has treated about 45 patients, which is not a lot in one sense, but it's I think there's been about 120 patients that have been treated in Australia so far. And I'll talk about that, and probably the one thing I'll say up front is I think there's a big difference between psilocybin and MDMA. And I think particularly in the PTSD world, I think MDMA is really going to change the paradigm completely. We're seeing people that are getting essentially sort of curative responses using MDMA therapy. So it's a very impressive treatment. And just, this is a bit of an obscure slide, but the reason I put it is because what I'm seeing in practice is that for every 150 odd TMS that I'm prescribing around 30 esketamine and maybe 1 to 2 psychedelic-assisted therapy. And the reason for this is because there are practical and logistic issues which go towards how available these treatments can be. And I don't think this is going to change, because unless we can completely sort of revamp the logistics and to some extent the side effects of these treatments, you're probably not going to see this change. I mean, the fact is, if you have TMS, a single treatment can take 15 minutes and it doesn't interfere with anything else. You can literally drive in your truck, have the treatment, drive off, continue your day. With esketamine, you're out of action probably until the following morning. You're not completely out of action, but you can't drive a car, which means you need someone else to pick you up and drop you off. With psychedelics, you're not out of action, but you probably need a week after the dosing day to really let yourself process and take time off. So just on the time commitment that's required for each of these treatments, there is going to be some practical reasons why TMS is probably going to be the first go-to, followed by esketamine, followed by psychedelics. And that probably won't change. So what is TMS treatment? So TMS stands for transcranial magnetic stimulation. How many people in the audience have actually heard of it? Okay, it's fantastic. When I first did these talks, I'd get like one person put their hand. So I think it says something about how available it's become, that now most people in this audience know what it is. TMS was the first of the sort of non-medication treatments, and in a simple terms, the way it works is it switches on the mood pathways, the positive. Use. The difference is that if you use a drug like a serotonin increasing drug, an SSRI, or any of the antidepressants, there's about 20 or 30 of them, they're all kind of in the same ballpark. Any of those treatments basically have a chemical activation of those positive mood pathways. So if you're someone who the chemical activity or activation system doesn't work properly, which is about a third of people, then it doesn't matter how many of these medications you give, they're not going to work properly. TMS works for those people, for some of those people, because it doesn't use that chemical activation system. It's basically a kind of uses that sort of electric motor idea, where you're using kind of magnets to create sort of electrical currents. It does that, and that activates it in a very direct way. And magnets have a couple of advantages. The first advantage of magnets is they don't hurt. So, it's not like electricity where you get a burn. Magnets are painless. The second advantage, which I think is even a bigger advantage, is that magnetic fields are very short range. Anyone who's held two magnets together knows that, they interact when they're close, but you don't have to go too far away when there's no interaction. And that's really powerful, because the reason why TMS, the biggest advantage of TMS is it has almost no side effects. And the reason it has almost no side effects is because as important as the areas you activate are all the areas you don't activate. So when you give someone, when you use our kind of MRI strength magnet to sort of activate the sort of depression centres in the brain, you're really only activating an area about a third the size of a golf ball. That's it. Everything else you're not touching. That means you're not getting any whole of brain effects, you're not getting any whole of body effects. And when you think about the problems that a lot of people have with the treatments for depression, whether they be tablets or even things like ketamine and things like that, it's about all the things that are non-core, all the collateral damage that you weren't expecting. You're trying to get that depression bit, but you've got all the other stuff as well. So you end up with sexual dysfunction, you end up with appetite problems, you end up with sleep problems, those sorts of things. You just don't see that with TMS. The one problem in the initial stages, which I think we're addressing more recently, is you needed to have a lot of TMS. So the way TMS works is it's a repetitive activation of the pathway. So the more you activate the pathway, the more embedded those positive mood circuits and the improvements, the upregulation of those is. So typically you have to do kind of 30 to 40 treatments. Now, when we originally started doing it, we used to do it every day. We used to do a treatment once a day, 5 days a week, 7 weeks. And that's a bit of a hassle for people because they've got to come and go for these appointments. Increasingly what we're seeing now are we're compressing the protocols. So, our basic protocols now are 2 treatments a day, delivered within half an hour, once a day over 4 weeks. And probably the most exciting thing we're seeing, because a lot of people, particularly in rural areas, aren't necessarily close to clinics, is we're able to further compress those protocols so that we can do what we call accelerated TMS, where you're doing 35 TMS over a 6-day period. So what that means is instead of coming to a clinic for a relatively brief intervention every day for 2 months, you can now come in, have a 2-hour appointment on 6 separate days over, a bit over a week, and you've basically done your acute course of treatment. Doesn't seem to be any increase in side effects, doesn't seem to be any decrease in effectiveness. You know, these aren't typically available to all groups, but DVA and the workers' comp groups and the first responder groups, you know, all of that has been supported within funding, and I imagine we'll eventually see Medicare come on board. They're always the last one to come on board. TMS is of the next step treatments, is the most standard, the most well established, the most well understood, the most well tolerated of the treatments. And there are very few people that can't have this treatment. So, you know, for the people that can't have this treatment are people that have got kind of, usually metal implanted devices in their head. So someone who's had a cochlear implant, you know, someone who has residual shrapnel in their head, if you're looking at a veteran group, they would be problematic. But some of the groups that you can use this for tells you how safe it is. So we use this treatment in pregnant women as a first-line treatment for depression. We use this treatment in frail elderly, you know, those kind of very elderly people that you really can't use any medication safely. So this is a safe treatment in that group. Pilots are able to use this treatment. Commercial pilots, you know, there's almost nothing you can treat commercial pilots with. So side effects, minimal, safe. I might just get, do you want to just set that up? I've got one of our patients, we did an interview on TV, one of our patients gave us was asked some questions, and I just think it's nice just to hear what someone actually says about the treatment.
We've got sound at the back, guys.
We did lip reading.
Excuse me, Ted. Over here. Have you looked at using fastings so you could use?
I was almost incapable of moving.
Sorry.
I'll come back to you.
I was almost.
How's TMS helped?
I was almost incapable of speech. I was almost incapable of moving. I would wake in the morning with this dreadful sense of a weight upon me that I could not get rid of. It was just appalling. When I look back on it, I'm just horrified. But for me, TMS really has been a game changer. And now I'm much, much better off. I don't wake up like that anymore. And my mood is much, much improved upon what it was in those days. And I'm just so pleased about it.
Well, what other treatments did you try? I think you said you had depression for 50 years. What did you try? I've
also had talking therapies, and cognitive behavioural therapy is one of those. And I've also been on a range of antidepressants. Cognitive behavioural therapy, in fact, is still very, very good. And I still use it if I want to confront particular thoughts at particular times. I could kick straight in with CBT. However, to raise my mood continuously over a long period of time, TMS has been the one that's done it for me.
Sounds quite miraculous, is it?
Oh, look, I think it is in a sense. Basically what you've got is a couple of magnets kind of pulsing a little bit there, and a sense of lightness can overcome me. It's just terrific. On occasions, I've almost gone to sleep during the treatment.
You sound like a new man.
I hope so.
And Ted, TMS, as you say, has been around since the 80s. It is quite common in other countries.
Thank you very much. Thank you very much, Jason, for that. So there was a question. I'm happy to sort of grab that question. Yeah. Did you have a question?
Yeah, can you use this if you go on a fasting? If you go into autophagy
Yep.
Just to help out and then use that as like an extra, or is it better to use that and then maybe do a fasting?
No, this is, I mean, we combine these with a whole range of treatments. There's no, I mean, I'm not sure whether there's a great benefit with fasting and TMS, but there's certainly no reason why you wouldn't do it.
Okay.
So TMS, as I said, I think if you had to say within the next step world, I think it's the first step in the next step world. I think ketamine is probably the second, the step you would take after that. And there are a lot of advantages to ketamine, and in particular with esketamine, there's you know, the advantage is that not everyone responds to every treatment, so you need to have something to treat the sort of residual group. So when I look at why we're doing sort of next step treatments, if 2/3 of people respond to antidepressants and CBT, that means 1/3 don't. If you then take that third and treat them with TMS, then roughly 2/3 will respond and 1/3 won't. So it's almost like sort of you know, my job, and I think the way we're going to sort of solve the sort of pandemic of depression, PTSD, anxiety is not going to be with a single treatment. It's going to be with an incremental approach. You know, if the tablets and the CBT works, great. It's easy, it's cheap, it's convenient. You just go ahead and do that. If it doesn't work, you do TMS. Now, for the third of people that don't respond to TMS, what do we do next? Esketamine, I think, is a great treatment because it also has a similar response rate. About 2/3 of the people that have esketamine will respond. And unlike TMS, it's not a direct activation. It is a chemical activation, but it's not using the SSRI, SNRI, serotonin, noradrenaline type activation. Pretty well every antidepressant is in that group. Esketamine uses a completely different sort of chemical system, which is why even if drugs haven't worked before, why there's still a 2 out of 3 chance that esketamine will work. One of the problems with esketamine, and the reason why I don't do it first, is because of the inconvenience factor. When you come in for esketamine, you basically have a 2-hour appointment twice a week for 4 weeks, and then a 2-hour appointment once a week for 4 weeks. That's your acute course. And then if it works, there'll be some kind of maintenance program, usually kind of once a week or once a fortnight, and that might continue for a period of time. Now, that's okay if it's TMS, because TMS you can just sort of go about your business. But with esketamine, one of the problems with it is you can't drive after the treatment. And it's a dissociative anaesthetic. So, you know, within that sort of 2-hour appointment, you'll have the nasal spray. People will be somewhat dissociated for about 20 minutes to 30 minutes, and then they spend about an hour and a half chilling out. We check people's blood pressure. It has systemic effects in the way that TMS doesn't. So the big advantage of esketamine is that 2 out of 3 people will respond, which is really important. If you're in that group that hasn't responded to drugs and TMS, you now have a choice of doing nothing or doing something which has a 2 out of 3 response rate. It has the advantage that it is more convenient than being in hospital. You know, it doesn't require a full-time commitment, but it has the disadvantage that it requires a greater commitment than something like TMS. And that's why, sorry, I have a question at the back.
So it's a question, is there a time when people build up a tolerance to that and it no longer works?
There doesn't seem to be a time that people deliver a tolerance, but I do think there is a time, and I think this applies to all treatments, where you make the decision to actually stop the treatment. And I think that decision to stop treatments is often based on how long you've been well and what the particular risk factors were when you're unwell. The actual nasal spray is very simple. It's a kind of pre-packaged 28 milligram nasal spray, and people usually have 1, 2 or 3 nasal sprays. And then it's done in a room and it's done under supervision, and people's blood pressure is checked, and then at the end of the treatment they can go back home. you probably can't go back to work after the treatment. So, but you can go home and do all your sorts of normal duties. So you'd be able to prepare a meal at home, look after yourself, supervise kids, those sorts of things. But you probably wouldn't be able to do complicated tasks. One that everyone's excited about is psychedelic-assisted therapy. I think when I started doing psychedelic-assisted therapy, I was really of the view that that psilocybin and MDMA were very similar, in that I'd be equally likely to use psilocybin for depression as I would be for MDMA for PTSD. I'll go into some of the detail in a bit, but as I've treated patients, I have my views on that have changed somewhat. I've become much more convinced about the benefits of MDMA for PTSD, and my threshold for using MDMA for PTSD has gone down dramatically. I've seen really dramatic responses, fairly consistent improvements. As more or less everybody we've used MDMA-assisted therapy for has improved to some extent, with the large majority of them improving dramatically. And I've seen almost nothing in the way of side effects. It's an incredibly safe treatment. Psilocybin, I've seen some really dramatic improvements, but I've also seen side effects and complications. So my level of respect for psilocybin has increased. I remain still quite cautious in terms of selecting people for treatment. Whereas with MDMA, my level of caution is probably lower than it was when I first started. We delivered the first treatments, but there is now something like 20 to 30 approved prescribers. So the way the TGA and what the government sort of approved this treatment is somewhat unique. They didn't approve the drug, so they didn't just say, well, you now use MDMA for PTSD and you can use psilocybin for depression. What they said is, we will approve an entire treatment program. So you've got to, the team needs to come to us and you need to write a protocol. You need to say how and when you're going to use this, what sort of therapy is going to be done with this, who's going to deliver that therapy, what are their qualifications, what sort of site are you going to do it in. You basically have to draw up the entire sort of business plan of the package of the care, and then they say, yes, we approve that, no, we don't. And it was very much, the focus in forums that I talked to is very much on either the MDMA or the psilocybin. But the focus of the approvals, and really I think probably the clinical use of these drugs, is that it assists therapy. One thing we know a good thing and a bad thing about these drugs from community use. So psilocybin and MDMA are hugely used in the community. I mean, the recreational use is incredible. There'd probably be tens of millions of doses of MDMA consumed every weekend around the world somewhere. So we know a lot about it. And what we know about the recreational use that's good is that both of these are reasonably safe. For the quantity of use of MDMA and psilocybin in the community, we get very little in the way of side effects, very little emergency department time is used up dealing with the acute problems related to those drugs. And we even know that in addiction recovery units, while it's pretty common to see people with cocaine or ice or alcohol, it's pretty rare to see people with isolated MDMA or psilocybin addiction. So we know it's safe, so that's good. But we also know it doesn't work by itself, because given how much MDMA is used recreationally, if it was really effective by itself, there'd be no PTSD left in the world. People would have just worked it out themselves, bought some MDMA and got better. And you could say the same for psilocybin and depression. If they worked entirely by themselves, then people would have already kind of solved the sort of depression epidemic. So it's something about the combination. And as I've been involved in this treatment, it's very clear to me that, and if we look at MDMA in particular, one of the blockers of recovery for PTSD is the enormous shame and psychological shutdown that people have around discussing the trauma, around emotionally approaching the trauma. And that makes any kind of therapy very difficult. Things like EMDR, which a number of the psychologists do, can be very helpful because they can sort of distract from that temporarily and allow you to sort of uncover that. But MDMA is almost the perfect drug to use in therapy with PTSD because it really selectively switches off the fear centres. It basically just gives you a 6 to 8 hour temporary off switch for all your fear centres. So you're actually able to bring into therapy and work with the therapist in a very kind of productive way. So my first experience of using this drug, I came out of it saying, well, this feels like I've just done a year's worth of therapy in a day. And the reason it felt like that is because I didn't have any of the normal blockages. Normally, if you're doing therapy, either as a patient or as a therapist, what happens is you come together for an hour. You're lucky if you do it once a week. More often, you're doing it once a month. You spend the first 15 minutes chit-chatting, just getting comfortable. The therapist is very concerned to get you out of the room, in a happy state. So they spend the last 15 minutes making sure everything's good. That gives you half an hour to actually deal with things. Within that half an hour, you've got all the normal kind of internal blockages to talking about whatever it is you need to talk about. So a lot of the time is wasted. Most of the time when people are doing therapy, you're looking for those little golden moments that occur because everything kind of fell into place at the right time in the right way. MDMA in a dosing day allows you to guarantee the perfect therapy day. And not only that, the dosing day itself is 8 hours, so it's a lot more therapy. And so, I'll show you some of the results we're getting later. For the people who are therapists within the room, it's a very conventional form of therapy. It's basically trauma therapy done well, done perfectly. Psilocybin, again, very different. This is the format that therapy follows, psychedelic-assisted therapy. One of the biggest problems in psychedelic-assisted therapy is I don't know how we're going to scale it, at all. And I started doing, every treatment I've done, I've thought, well, how can I, if this is a good treatment, so with TMS, I said, well, if this is a good treatment, what are the problems? We've got to get it out there in the community. We've got to get lots of people getting accessibility to it. You can't be too far from a clinic, that sort of thing. Psychedelic-assisted therapy, in every treatment, there's about 100 hours of therapist time per patient that goes in. So you've got 3 dosing days, you've got 2 therapists there, one of which, according to the rules of the game at the moment, has to either be a clinical psychologist or a psychiatrist. So you have to have a minimum of 40 of those 100 hours, has to be face-to-face with either a clinical psychologist or a psychiatrist. Very expensive, very rare resources. The other time is registered nurses, psychologists, social workers, people with experience. 100 hours of very senior therapist time means that the cost of these treatments, which are quoted anywhere from sort of 20,000 at the very low end to 35,000 to 40,000 at the high end, the cost of the treatment is 80% plus personnel cost. But more importantly, the personnel, even if the government said, well, look, we're just going to put $1 trillion into this and, unlimited money, there's just not enough of these therapists out there. There's 3,000 clinical psychologists in Australia. There's 3,000 psychiatrists. That's it. There's maybe 15,000, another 15, 20,000 psychologists out there. There's a real limited number of people out there. So that's one of the problems that I see. So we see great results, and I'll show you some of the results. So I'll start with the psilocybin. So, this is our numbers just from last year. When we sort of pulled them together, we had sort of 8 psilocybin patients who went through. You can see that they're from beginning of treatment to end of treatment, which is at the low point of the trough. There's a significant improvement in the PHQ-9. We did about 20 different rating scales. They all follow a similar sort of pattern. And then there's a little bit of backsliding, you know, if you're looking at the people kind of 3-6 months down the track. You know, my sort of take-home sort of anecdotally is that, you know, it's a bit kind of all or nothing in this group. You know, I'm seeing people with like phenomenal results, and then I'm seeing people, you know, with almost no results or even some negative results. If we go into MDMA, interesting in this group, I treated the very first veteran with, you know, with psychedelic-assisted therapy in Australia. I've treated a number of police. I was expecting that the PTSD group would be mostly male, but our group was about 50-50, and it was a whole range of trauma. So it wasn't just kind of first responder veteran trauma, it was also sort of sexual assault, domestic violence trauma within there. So a very mixed group, and what we saw was, if I can just get this, and this is the most exciting thing about this treatment, is people get better from beginning to end of treatment, which is in some sense not surprising, because if you spend 100 hours with someone over 3 months, you'd expect you'd get some result. But what's really impressive is when you end the program, they go home, you keep on following them up, and then these only go out to 3 months, but we've now got 6 and 9 and 12-month data. People just keep on getting better. It's almost like what you've done is by kind of having those kind of intensive therapy, by allowing people to sort of benchmark a new normal for themselves, they're able to go home and continue the kind of self-therapy, you know. And a lot of these people are actually not even seeing their therapists that they'd normally seen prior to that with the same level of frequency. So really impressive treatments. So at the moment, you know, the barriers to treatment are funding and cost. And fortunately with TMS, you know, there's pretty broad funding. With esketamine, there's pretty broad funding. With psychedelics, probably one of the most exciting things that's on the horizon is that DVA has been threatening for about 12 months to fund psychedelic-assisted therapy. But even outside of the DVA, we've seen some of the private health funds looking at this. So groups like Medibank have set up a clinical trial for psychedelic-assisted therapy, which is really exciting. And again, we're interested in seeing patients with depression, anxiety, and PTSD. I'll finish up with one more sort of call out to the pro-patria people. I just thank Jason personally for the sort of support for me personally and for Monarch in general, for the work that you and the team at Pro-Patria have done. It's been absolutely phenomenal. We're very proud to be co-located in Pro-Patria, and we hope to stay there for a very, very long time and continue to increase the number of services we offer there. So thank you, and feel free, if you need to make referrals, you can do it through Pro-Patria or come directly through our website. So thank you.